which is pulmonary atresia intact ventricular septum. For the luck of the surgeon, now it's more of interventional cardiology. At least the initial stage of its presentation is an interventional cardiology subject due to advances in intervention. So you may not see a lot of them these days, though they are rare in the initial stage. But you will face them when they come for a second stage of repair. When they come for either biventricular or single ventricular or 1.5 ventricular repair, which kind of repair you are going to choose. I want to start with this slide. In fact, it's a meta-analysis by Vivi Lee and others in 2015. If you see, I would just want from you to concentrate on the second column and the last column. You see the mortality rate is still high. Even at 2011, the 10-year survival only 80%. So it's a disease that carry a lot of mortality and morbidity, and we will come to know why this in the coming few slides. Pulmonary atresia, intact ventricular septum, is a malformation of the right side cardiac structure with heterogeneous morphological appearance. Some they call it hypoplastic right heart syndrome, and it's associated with atresia of pulmonary valve combined with a ventricular atresia in around quarter of or 1/5 of the cases. Intact ventricular septum, a hypoplasia of tricuspid valve, right ventricle, and pulmonary trunk. Significant hypertrophy of right ventricle. Usually a normal size pulmonary artery branches with a little bit hypoplastic MBA. Rarely you'll find the MBA a thread-like, but always there is an MBA, and always there is almost a normal sized branch pulmonary arteries, unlike pulmonary atresia with a VSD. A right atrial enlargement, especially if it is associated with restrictive intra-atrial communication or a severe TR. Intra-atrial communication could be in a form of BFO or a small ASD. Right ventricular to coronary fistula is a common in these cases. This cartoon shows you that if you see the RV is small because of atresia pulmonary valve, and we know that the growth in utero growth of any part of the circulation is related to how much flow through this part of the circulation. So, as in mitral atresia, mitral stenosis, the LV gets small. Here again, or aortic atresia, here again, the pulmonary atresia is associated with hypoplastic RV, and because the tricuspid valve is part of the RV structurally and development, it's also a small in these cases. This is again as we see that the pulmonary valve, in fact, is rise from the RV, and it started at stage 15 in embryology, is a semilunar valve and guarding the RV outflow tract. Again, this is another cartoon show you how much the hypoplasia, valvular atresia of pulmonary valve resulted in the hypoplasia in the RV, small sinus portion, good outlet portion, and good inlet portion. And this has come to another concept that we are coming to, that the pulmonary valve could be will form, but is fused commissure. And the diaphragm-like, this is an 80%. We call it a membranous atresia of the pulmonary valve. For you, in the current days, you don't see it, because once they come to the ICU, is usually taken by the second day by the cardiologist to perforate this valve. Some cases, they have a muscular and ventricular atresia in around 20 cases, 20% of the cases, and this is the muscular pulmonary atresia, you don't see a flow. This is totally atretic part of the outflow. Pulmonary artery trunk really atretic, usually to smaller size, and BAs, branch BAs, usually near a normal size. Is in fact closely related to what we call it a critical pulmonary stenosis. Even critical pulmonary stenosis could be associated with some sort of hypoplastic right-sided ventricle. And though it have been usually we study it in a different chapter than pulmonary atresia and ventricular septum. Right ventricle, the myocardium of the right ventricle show a variable degree of ischemia, infarction, fibrosis, endocardial fibrosis, poor compliant RV, and may contribute to surgical mortality. And even after the balloon dilatation of pulmonary valve, even if we release the whole gradient, sometimes these patients will stay on prostatin, or they need a stenting of the duct for a longer time, at least sometimes up to two months. Still, this RV regenerate again and start to support circulation. Cavity variable in size, but severely reduced in 60% with a reduced capacity also. Cavity enlarged and an Epstein malformation with severe TR, and 5% of the patient with pulmonary atresia, intact ventricular septum. RV sinusoid, which is endothelial-lined blind channels within the substance of RV mass, communicated with the RV cavity in around 50% of the cases. Now, communication between this sinusoid and the coronary arteries, we will come to speak about it. It's much less than this number, but the RV sinusoid is part of the development of the heart itself. So, because of the RV pressure is still high, they fail to regress with time during embryo life. Now, the RV cavity could be severely obliterated. If you see here, you see only the inlet portion, and here you can see the inlet and outlet in the moderate hypoplasia with muscle apical crowding, which have been advised to resect it during surgery by Emil Basha and also by Kawashima in form of as a part of first stage surgical repair. Now, RV size, as we will come to see, this is a normal size. This is just a cartoon, and in A, and in B is hypoplastic, but it's tripartite. You see the inlet portion, you see the apical portion, and you see the outlet portion. So it's a three portion of the RV is still present. And the C, you see only the inlet and the outlet, but the apical portion is already obliterated by hypertrophied muscle. And in D is only the inlet is available. And in these cases, you find the muscular atresia obliterating the RVUT. And RV should be adequate to support all cardiac output and therefore allow biventricular circulation on long term. And we will come to know how you differentiate between those patients who can go for a biventricular heart from those who should go for a univentricular or 1.5 ventricle. RV size is correlated with the diameter of tricuspid valve, especially what we call it a Z value of the tricuspid valve. Now, coronary arteries, because of high pressure of the RV, especially those patients who don't have any TR, so the RV pressure is always suprasystemic, they maintain the coronary sinusoid. And this coronary sinusoid may communicate with the RV, with the coronary circulation. And if you see this patient is having LAD stenosis with sinusoid communicating with the distal LAD. So the distal LAD, in fact, is supplied by the RV pressure. Once you decompress the RV, this patient will have an infarction. So it's crucially important to find which cases who are going to develop, who are suitable for biventricular repair and immediate decompression of the RV. And this is again pathological specimen showing a dilated left main coronary artery with a fistula, with atretic RCA. Again, this is an aortic injection. Coronary injection through the aorta. It showed an RCA which is dilated, and it fell retrogradely, the dye going into the RV. This is again, you see between this is the RV, diminuted cavity, delineating the coronary anatomy. Again, RV injection in these cases, unrepaired cases, may delineate a coronary fistula to the coronary itself. So it's as a rule, once if you have RV, small RV, especially those with a diminuted tricuspid valve, with a Z value less than 4, you should suspect an RV-dependent coronary circulation. Tricuspid valve is rarely normal in these cases. It can be associated with a thickened leaflet, chordae abnormal dimension, correlate with the size of right ventricular cavity. Right atrium could be enlarged with an ASD or BFO. Intra-atrial communication mostly in a stretched BFO, but sometimes you have a small ASD. And in fact, those patients who don't have a BFO or ASD, they die on ETRO, and usually in a form of abortion quite early in pregnancy. Now, mitral valve in 50% is abnormal, but in most of the cases is functional. Any enlargement and hypertrophy you can find. Left ventricular fibroelastase is common. Rarely these cases could be associated with left ventricular outflow or tract obstruction. Pulmonary blood flow is provided usually through a PDA, and rarely a multiple aortopulmonary collateral supplying the pulmonary blood flow. Unlike pulmonary atresia with VSD, which is associated with collaterals. Now, the pathophysiology. Now by explaining the anatomy, you expected the pathophysiology. The PDA supplying the pulmonary arteries blood flow, but the RV, because it's systemic, resulting in non-compliant RV, high RA pressure, right to left shunt through the ESD or BFO, and resulting in a stenosis. RV usually small and with abnormal tricuspid valve, resulting in TR. Heart failure, or if intra-atrial communication is restrictive. Right ventricular fistula with right ventricular dependent coronary circulation is in 10%. And we say that persistent sinusoids in 50% of the cases. But RV dependent coronary circulation is in 10%. Pulmonary blood flow is duct dependent, and usually these patients developed immediately after birth what we call it stenosis and acidosis. Usually the history, immediately severe stenosis and acidosis after birth, usually empirical, the unit start on protein, and then they ask for the investigation. The first investigation, as you expect, is an X-ray, is not of much help value, but as you see, the pulmonary valve shadow is absent, and the lungs are hypo-perfused. Some cases, especially with a severe TR, they have an enlarged cardiac shadow, and in a patient with an episteem associated with pulmonary atresia, they have wall-to-wall heart as a quite grave prognosis. The X-ray will help you in showing where is the aortic arch if you are going to do a surgical shunt. Associated lung disease and associated skeletal anomalies which is quite rare, is also can be shown in the X-ray. Because of absence of hypoplastic RV, usually left axis deviation is available on is what you see in the ECG. Now, what the goal of echocardiography is the main diagnostic station is an echocardiography. It first of all, it will document absence of forward flow in right ventricular outflow tract. Absent forward flow could be in the pulmonary atresia or could be in a functional pulmonary atresia that can be associated with a dysfunctional right ventricle, as in a patient with an episteme anomaly, severe neonatal episteme. Second thing, evaluate the tricuspid valve, mitral valve size, anatomy of the infundibulum, evaluate the competence of the tricuspid valve, and because of the TR, you can measure the right ventricular pressure, and you find in many cases the right ventricular pressure is a suprasystemic. Evaluate the size of the right ventricle. Is it monopartite, bipartite, or tripartite? Evaluate the source of pulmonary blood flow, usually in a form of a duct. Evaluate the pulmonary artery confluence, and this is essentially if the patient is going for a duct stenting or going for a surgical reconstruction and a shunt. Detect the presence of right coronary artery sinusoid, and whether there is a right ventricular dependent coronary circulation. This will not be answered by echocardiography. Always you require an angiogram to delineate a right ventricular dependent coronary circulation. And this is the echo. As you see, it could show morphology for you. And if you see this patient, the apical part of the RV is just totally filled with muscles, with a diminuted RV cavity and smallish tricuspid valve. Again, if you can see that small tricuspid valve and a sinusoid available with it. Tricuspid valve Z value is crucial and the coronal stone and in the diagnosis itself. RV apical muscle crowding, and also to rule out coronary fistula. Cath is important for RV angio, or also orthogram if the coronary anatomy needs to be defined. Though in these days, the Cath is mainly used for a therapeutic. So most of the pulmonary atresia intact ventricular system, in fact, they go to the Cath lab in an attempt to either establish a forward flow through the pulmonary valve or putting a ductal stent at the time of cardiac cath. Again, absence of forward flow is a diagnostic. Smallish tricuspid valve. In this case, the patient is having a better RV than the previous case. Again, you can measure the tricuspid and also the mitral to see the mitral tricuspid ratio. A ratio less than 0.75 tricuspid to mitral may preclude biventricular repair in these cases. Tricuspid valve regurgitation is important, and tricuspid valve regurgitation gradient in this case, if you see the patient is having almost 120 gradient, plus the CVB will give you the real right ventricular systolic pressure. And if you divide it by the LV or the systemic pressure, give you RV to LV pressure gradient. Catheterization is essentially therapeutic value in the pulmonary atresia intact ventricular septum. In the absence of infundibular atresia, the valve may be perforated, usually the radio frequency, and sometimes with a laser, depending on the unit that you are working, with a subsequent balloon dilatation. Once they perforate, they pass a guide wire, and over the guide wire, they balloon it through a balloon. It will help to define a coronary sinusoid and coronary fistula, and therefore contraindication for RV decompression if you have a patient with a RV dependent coronary circulation. This is a patient with a with an RV angio showing good inlet, good outlet, membranous atresia of tricuspid of the pulmonary valve, and reasonable size of tricuspid valve, and apical muscle crowding, though a reasonable size of apex. More diminuted here, and in this patient is almost having the same pathology. RV angiogram also can show inlet, outlet, and also can show the retrograde filling of the coronary with an RV to coronary fistula formation. Also, during angiogram, you may also delineate the pulmonary arteries, and if you study if the patient is suitable for a ductal stent or not. Again, this is another case showing a good RV size with a membranous atresia of the RV. Again, this is a patient showing RV-dependent coronary circulation. If you see that there is a RV injection giving a retrograde filling of the coronary toward the aorta, at the same time it delineates the LAD is the distal mid and distal LAD is filled with the RV injection. CT scan could be done, though it's not essential to see the. You can see the pulmonary artery and their size. Where is the duct inserting? If there is any abnormalities in or hypoplasia of some part of the pulmonary artery, and also it can show if there is any fistula formation and if there is any coronary stenosis. Medical management, most of the patients they started empirically on prostaglandin. You need to correct acidosis and mechanical ventilation may be needed. Echo and assessment of tricuspid pulmonary valve, RV size, absence of RV-dependent coronary circulation, and treatment strategy usually depend on the RV size and presence or absence of right ventricular coronary dependent circulation can be either biventricular half, 1.5 ventricle, or single ventricle. And usually we divide the patient into groups. Group A, and they have a sufficient RV size, tricuspid valve Z value more than minus 2.5 or minus 2, membranous atresia with a well-developed infundibulum, variable degree of TR, they may have a severe TR, but they have a good RV. No major coronary sinusoid, and tricuspid valve annulus more than 8, or tricuspid valve annulus index to normal more than 70%. Then these patients usually go radio frequency perforation, and rarely these days need a surgical commissurotomy as before. They may need to stay on Borstein for a while, post-op, till the RV recover. But this is most of these patients, they go without any further neonatal intervention. Group B is an intermediate case, intermediate stage, a borderline RV with some sort of hypoplasia, usually an apical muscle crowding obliterate the apex with a bipartite RV. Tricuspid Z value is between -5 to -2.5. They have sometimes bedded infundibulum, or they may have a hypoplasia or a stenosis of the infundibulum itself with a hypoplastic pulmonary valve annulus, variable degree of TR, and the sinusoid could be present. Tricuspid valve annulus more than 5 and less than 8. And these patients, they may go to RP radiofrequency perforation of the pulmonary valve, but they need a ductal stent or a BT shot, depending on the unit. Again, rarely we take these patients for surgical valvotomy. Now, the patient with a severe hypoplasia, with a tricuspid valve less than Z value less than 5, and some unit they consider less than 4, no trabecular RV, infundibulum usually atretic, mostly no TR because the RV is no volume, so the blood going there and usually they have often a large sinusoid, RV pressure dependent coronary circulation, because of no TR they develop, most of them they develop high RV pressure with a RV dependent coronary circulation. A tricuspid valve Z value, because there is no much flow through the RV, less than 5 and millimeter. So these patients usually they need a ductal stent with balloon atrial septostomy or PT shunt with a balloon atrial septostomy or septectomy. Management catheterization required with a proper management. Most of the patients they need the cath to manage them. As we said, you pass a radio frequency or with a special device, you perforate the valve and then pass a guide wire and offer the guide wire a balloon and then dilatation plus minus a ductal stent depending on the RV size. Mortality rate is around 3% in these cases. Repeat balloon may be needed. ASD device later on or and BDA closure may be needed a few months after testing the adequacy of the RV to maintain the circulation. These cases, especially if they ended with a severe BI, they are a candidate for percutaneous pulmonary valve implantation. Balloon atrial septostomy needed, especially if this case is for two ventricular pathway, then avoid balloon atrial septostomy, especially if the mean atrial pressure gradient between RA and LA is less than 5, and there is no restrictive BFO, and there is no signs of systemic venous congestion. Those patients who's going for a single ventricle pathway or RV size is small, then they should go for balloon septostomy. Otherwise, they may come with a restrictive intra-atrial communication and right side heart failure, even months after intervention. This patient, as we said, can go for biventricular or univentricular pathway, depending on the type of atresia, right ventricular anatomy, a tricuspid Z value, function, and right ventricular to coronary fistula, as we said. Now, what is the reason beyond this? And as we see, this is in the meta-analysis by Vivi Lee that I mentioned before. If you see, there are many criteria have been taken for biventricular adequacy of biventricular vein. One of them, tricuspid valve diameter more than 70% diameter of the normal, or tricuspid valve Z value more than minus 2.5, or depend on the study itself, or right ventricular end diastolic volume more than 70% of normal, or tricuspid value, Z value in another study, RV tricuspid value index, which is taking the RV end diastolic volume over the tricuspid valve diameter, and then see what is the index between them, and then tricuspid value, Z value, another study. So these are the criteria, either tricuspid valve diameter or Z value or RV end diastolic volume or tricuspid mitral ratio have been used for choosing the patient for biventricular or univentricular vein. Again, presence or absence of RV dependent coronary circulation is crucial in choosing which pathway the patient should go on. One of the main landmark studies have been published by Frank Haney and others. This is in '93 by showing a multi-institutional study. And if you see all those patients more than minus 2 tricuspid Z value, they ended with a 2 ventricular repair. Those in less than -4 Z value, they ended with 1.5 with a single ventricle repair. Between -4 and -2 is a mixed circulation, and they may be suitable for 1.5 ventricle according to some literature. Again, another study, more recent study, showing that patient with a Z value more than -2.5 they can go for a biventricular repair, but those patients with a less than 4.5 should go for a univentricular repair. Another recent study showed that Z value again should be more than -2, and those less than -2 should discourage you for going for biventricular repair. Again, another study from Netherlands. They studied 60 patients, and they defined the patient according to the Z value into mild, moderate, and severe hypoplasia. And they found that they achieved the biventricular repair in the mild in around 90%. And those moderate cases, there's only 20% they ended with biventricular, and none of the patients with a severe hypoplasia ended with a biventricular repair. And if you see that the coronary fistula itself is associated with a severe RV hypoplasia in around 50% of cases, and usually they end with a singular ventricular pathway. Tricuspid Z value, again, when you see tricuspid Z value in what we call it literature, is tricuspid diameter to index to the body surface area of 0.2 square meter in what we call it an unit. And in these cases, if you take the Z value, I want you to just to see that the Z value of, for example, here in -5 and -5 in this series could be in fact only on 9 millimeters. So it's a difference between case and case, and there is a discrepancy because they use a different data set for scoring of tricuspid Z value. For example, some unit they use a totally different Z value, and they which could result in a Z value that is much small, and you wonder how they achieve a biventricular repair. If you understand from where they extract the Z value, you understand what is that, why they choose it. In fact, -5 Dubini Z value may associated with -1 only Rolat Z value, and this is resulted because the Z value score is totally different, and they want to show you this is the data set or data that extract the Z value on the left side, the reference, and these are the program that we use the Z value to start with. And if you go to, for example, 10 millimeter, now in parameters in Dubini 1999 is -3.4. So this patient is obviously not suitable for biventricular repair. Again, in 9 millimeter is -4. But if you go to parameters from the American Association of Echocardiography, is only -1.8 9 millimeter. So this patient could easily go for a biventricular repair. So when you take Z value in literature, be sure what kind of Z value. But in general, if you use the American Association of Echocardiography data references and you use a parameters program, usually -2 to 2.5 is the cut point for a biventricular repair or a single ventricle repair. Again, other problems with the Z value that it does not is addresses only one problem, the tricuspid valve, only the annular size, but it never discusses the function of tricuspid valve, leaflet morphology, subvalvular apparatus, which may not help. If you have a borderline tricuspid valve that is severely leaking, then there is no point for long biventricular repair, because this to fix the tricuspid valve, you have to further undersize it, and because if it's all now is borderline, you cannot do this. And this is another study show you how it's important that the tricuspid valve Z value may not associated with the function of tricuspid valve, and the fact that the smaller Z value, the better function regarding regurgitation of the tricuspid valve. And if you see that -4 is none of them associated with Z value, is none of them associated with severe TR, but those patients with a Z value that around -1, most of them end with a in fact, most of the patients coming with a severe TR, they are of a Z value, of mean Z value of -1. Again, RV index, which is an interesting volume index, is a very interesting phenomena. This is used before through the right ventriculography and calculating the RV and tricuspid valve index, and then RV to tricuspid valve index ratio. And this is Yoshimura from Japan, showing that most of the patients who needed only a valvotomy, they are of index for a volume of more than 0.7, and those who are RV index volume, those between 0.35 and 0.7, they need a valvotomy or beta blocker, and those lists that are 0.35, they go most of the time they go into biventricular repair. Those having RV coronary vistula, they end with a single ventricle repair. RV tricuspid Z value index, sorry, more than 0.4 is as we see now in this graph. Those tricuspid valve index to normal and dry RV index to normal. If you take these patients who are ended with a single ventricle or one and a half ventricle, depend on these patients, because if they have a lower index, they ended with having a fontan, and those patients who is having a patient who is having a higher index, they ended to have a biventricular repair. Between them is a 1.5 ventricular repair, as you see this black stars. RV dependent coronary circulation is a very important, is carrying a high mortality, as you see. This is a study from Boston by Chris Belisarian. They studied 32 patients with pulmonary atresia, intact ventricular system with an RV dependent coronary circulation, who underwent the initial evaluation. Mortality rate was around 20%. Those patients who is having aortocoronary atresia is associated with 100% mortality. And nowadays, the current practice is any patient who is having a coronary atresia should go for what we call it should go for a heart transplant to start with. Early mortality appeared to be related to ischemia at the time of the VT shunt, especially if you go on cardiopulmonary bypass, because you suddenly decompress the RV at that time. This patient, again, showing another nice study by Emil Basha and group when he was in Columbia University, New York, and showing that RV-dependent coronary circulation is associated with a high early mortality, especially a patient with a coronary atresia. This patient is having this is the RV function, showing that even the proximal coronary is supplied from the RV, and when you try to inject in the aorta, the left main coronary artery is atretic and is not showing up. Even the right side is atretic early in the course of the coronary history. So coronary atresia is associated with a very high mortality, almost 100% mortality. Now, this is the same long-term study for long-term outcome in the patient with pulmonary atresia and ventricular septum. Those who go into biventricular usually have a good prognosis. Those who go into univentricular pathway, if they have non-RV dependent coronary circulation, most of them will get survived, even they go into a single ventricle. But if they got a right ventricular dependent coronary circulation, most of them they die, and a few percent, maybe less than 40% of them, they will end with a Fontan circulation, and we don't know the long-term outcome of these patients. If you see now, this is RV-dependent coronary circulation. They have quite an early mortality. Now, again, pulmonary atresia intact ventricular septum, and if you don't have RV-dependent coronary circulation, adequate RV should go for biventricular heart. Borderline should go 1.5 ventricle. Inadequate RV should go for either univentricular heart or 1.5 ventricle. RV-dependent coronary circulation, those with atresia should go with a heart transplant, and those without atresia and without signs of ischemia should go for a univentricular heart. Usually, as we say, the radio frequency perforation plus minus ductal stenting, or surgical valvotomy plus minus septostomy, septicectomy, and BT shunt. Ductal stent plus balloon artery septostomy or BT shunt plus balloon artery septostomy could be considered for those patients who are going for a single ventricle pathway. Again, this is a study from Japan, from Shinji Sano group, 50 patients. They do what we call it of RV apical overhaul. I mean, they take the muscle crowding of the RV and they look for the RV growth, and they found the RV growth seen only in the patient who achieved biventricular repair. However, it's not seen in the patient with having 1.5 ventricle repair. Major RV fistula is a strong predictor of proceeding into a single ventricle pathway. So this is another study which is going with the same line as we said. Again, showing that the RV grow if you achieve biventricular repair and not in the 1.5 ventricular repair. Again, tricuspid Z value score. Now, 1.5 ventricle. This is a very controversial subject. Only limited evidence is available whether the clinical outcome of 1.5 ventricle is superior to univentricular repair. Exercise capacity and cardiac reserve showed no significance in 2 studies between the 2 groups, but better chronotropic response was maintained in 1.5 ventricle repair group, though the functional status is almost the same. Again, this is a study by Tara Karamolo showing the same that achievement of survival of biventricular repair is this is a multi-center study, or I think, yeah, multi-center study. showing that the biventricular repair is only achievement with can be on the cost of load deficit of exercise capacity. So some patients, the better outcome may be achieved in the borderline with a 1.5 ventricular or univentricular repair. And this is as you can see between a peak of consumption and the initial of oxygen consumption and the initial tricuspid valve size. Again, exercise testing, most of the patients, they perform less than normal. But the less the tricuspid valve Z value, the worse the function itself. So this is a study that show that you shouldn't push your patient for biventricular repair if they are a borderline because they may not get benefit. Again, a study by Richard Jonas and others show that if patients are satisfied, well, excellent survival can be achieved in treatment of pulmonary atresia and ventricular intact ventricular septum. This result may be at a price of achieving 1.5 ventricle as opposed of 2 points ventricular repair. This is again a study that show that you shouldn't push your patient for biventricular repair if they got a borderline RV, especially those less than 2 the tricuspid Z value. Surgical management, small size RV or that of tricuspid valve, muscular pulmonary atresia, the presence of absence of coronary sinusoid or coronary anatomy is important, dictate the surgical procedure in an infant with pulmonary atresia and intact ventricular septum. These patients could go for a 2 ventricular, 1.5 ventricular, or 1 ventricular repair, depending on the Z value. I will not go too much, but the first stage may go into a connection between RV and BA, which rarely we do, and usually in form of right ventricular outflow batch plus minus BT shunt. RV growth is monitored by echo. Cardiac catheterization can be performed at the age of 6 months. The surgical procedure if the RV increased and the arterial oxygen saturation stayed greater than 70 despite balloon occlusion, then this patient could go for a second stage. Near normal BA pressure at balloon testing and closure of the ASD itself. Two-stage ventricular second stage, usually in form of achievement of RV to pulmonary artery connection and closing of the ASD or making it small and leaving the small fenestration for later cordial transcatheter. Mortality rate is still high in these cases. 1.5 ventricle, as we mentioned, usually in the form of a glen plus restriction of the ASD or total closure of the ASD. 1.5 ventricle, as we said, we mentioned about it. But the beauty of 1.5 ventricle that always you can shift this patient into a full-time if they failed 1.5 ventricle. 1.5 ventricle, if any patient monopartate, then they should go for univentricular repair. Z value less than -4, they should go for initially for single ventricular repair. Those patients with RV dependent coronary circulation, they should go for univentricular repair without compressing the RV. Even if your patient comes to a second stage or a fontan, then you have to keep the RV filled through the blood coming from the pump itself and keep it hypertensive to support the coronary circulation during the pump itself. This is a fontana, hemifontana, I will not go. Special cases like pulmonary atresia intact ventricular septum with Epstein result in a thin-walled RV, dilated RV with Epsteinoid valve. These carry a very poor prognosis. And probably RV thromboexclusion, closing this tricuspid valve with leafing fenestration in the patch itself that you close, and this patient should go for one ventricular repair. Again, special cases, we mentioned coronary atresia. These cases should go straight forward, should be referred to heart transplant in neonatal period. Now, again, I have to mention for you, repeating the same slide, that you should stratify your patient depending on the G value and also the tricuspid valve annulus and also the RV index, volume index, into group A, group B, and group C. And group A, usually, as a surgeon these days, you don't see. Mostly you see a patient with a group C or a group B coming for you at a second stage, because most of the time now they go for ductal stenting, especially they have, in most of the cases, they have a normal or near normal pulmonary arteries. So most of the time you don't see them. But if you get forced to do them, then a BT shunt may be a good option. Now, in conclusion, despite current development of congenital heart treatment, pulmonary atresia intact ventricular septum still carry considerable risk, especially in early neonatal period. The main goal for treatment is to improve the systemic arterial oxygenation and, whenever possible, establish a forward flow through right ventricle. Choosing between pathway is straightforward for those patients at the end of the morphological spectrum. A patient with minus Z value, tricuspid valve Z value of -1 and tripartite RV is obviously for biventricular repair. This patient with a monopartite RV and tricuspid Z value of -5 and RV dependent coronary circulation is again obvious for a univentricular repair. So those patients who are between them then is really a big dilemma. Though if you stick to the rules of -2, more than -2 biventricular repair, less than -2 either 1.5 ventricular or univentricular repair. Again, coronary anomalies and tricuspid valve function should be taken in consideration in initial plan. Forcing borderline cases for biventricular repair may be at a cost of late deficit in the exercise capacity, emphasizing that better outcome may be achieved in this subset of patients with a univentricular repair. I mean those between -4 and -2 Z value, maybe they better go for a univentricular rather than biventricular repair. Though 1.5 ventricular repair looks appealing, recent report of conversion of 1.5 ventricular repair, 1.5 ventricle into a single ventricle should be taken in consideration. Thank you.
Thank you very much, Doctor. Yes, Doctor, I have a few questions. For those borderline cases with Z value of -2 to
-4 to -2.
If we decided to take them for, they failed this kind of repair, and then we shift that to univentricular repair. Does this increase their mortality?
No, in fact, stretching them into, I showed those in, I think in Boston group, they show a mortality which is 18%. This initially because they try to stretch the cases for biventricular repair. Now, if you have a borderline case, maybe it's better to go for univentricular repair. Now, if you shift them from biventricular repair to univentricular repair because of they failed biventricular repair, then I think they shouldn't have a mortality more than 5% as the initial cases for a univentricular repair. Any other question?
Thank you, Dr. Abdularaoof. Kindly, regarding what's the trick in the patients that depend coronary circulation dependence.
في أحد عنده مشكلة بالصوت؟
If I'm going on pump أنت عندك مشكلة في الصوت يا مرتضى. When
طيب.
I'm going on pump,
Yes.
You mentioned that I need to be, because once we go on pump, we decompress the RV, so we'll go directly to the RV, maybe RV infarction. So what I have to do, I just to be prepared to clamp, or what's the trick I have to do? This is one. And the second one, in those cases, what is the rule of closing the tricuspid? I think you mentioned it, but if you can kindly elaborate on it.
Yes. RV, dependent coronary circulation. First of all, you should avoid going on pump in these cases, especially in the initial stage. Now, if you are forced to go on pump, then you can use what we call it a me approach, or it's have been, in fact, initially started by Japanese group and then published with Roger Me early in 1990s. What they do, they bring up an arterial oxygen through a Y connection through the arterial line and during the pump, and pass it through the tricuspid through bursting the RA to the tricuspid valve into the RV. So the RV now is supplied with a good flow of unoxygenated blood. This trick you can use it. It's difficult to use it in unit, but you can use it when the patient coming for a Fontan, for example, or a patient coming for a Glen, a bigger patient. Now, if you are if you suddenly discover this during surgery, in neonatal period, unfortunately, you don't have much to do unless you use this technique. Or if you have only a stenosis, then you can cross clamp the baby and give a cardioplegia. But my advice to you, don't take any patient with a pulmonary atresia, intact ventricular septum, to the OR without delineation of the RV anatomy and the coronary anatomy. I have been burned several times because I took it lightly because of the RV size was apparently okay, but in fact still there is a good there is still, though it's not common to have a RV dependent coronary circulation in those patient borderline line RV.
Okay, that mean I need to have a coronary angio with any patient with a borderline, but patient with all the three components of the RV, at that time, we'll tripartite, that kind of patient, also I need to do for them coronary angio or no need?
So these cases you will not see these days. Now I don't know any center in Saudi Arabia who in which the cardiologists they do an intervention, they don't have a radio frequency or laser perforation of the pulmonary valve. It's available there. So okay. In fact, in practical life, you don't see, unless you go, for example, in Sudan or Tanzania or Mauritania or somewhere that you go into a mission and then you suddenly you find the patient with a pulmonary atresia and intact ventricular septum. Then in these cases, you can ask for a coronary angio to start with. Mm-hmm. And then if you open the patient and you see dilated coronaries, then again, this is a very, I'll be cautious not to go on pump and do anything for them. Maybe I put only a BT shunt and come out.
Okay, clear. Thank you, Dr. Abdularaoof.
I think it's not unfair to ask you a lot of questions about pulmonary atresia and intact ventricular septum in the exam, because this is a very purely pediatric, and in fact now shifted from the surgical arena into pediatric cardiology, pathology itself. But anyway, you may have a patient in the during your consultantship, and they present a case during the meeting, so you have an answer for it. Thank you.
Thank you very much.
Again, ya Shabab, something which I mentioned for you. For those who want to a pediatric, the Z value is not a Z value for everybody. The Z value depend on the center and depend on the data set they use and depend on the program that they use. And so this is not only for pulmonary valve or tricuspid valve, for everything in the heart. So be cautious when you read about Z value in the literature and see which Z value in fact they are using, and which Z value you should know what Z value you use in your unit. In our unit, we use the American Association of Pediatric Cardiology, echocardiography, sorry, and we use the program, we call it parameters program. Thank you.
Thank you, Dr. Abdularaoof.
دكتور
Hi.
هو بالنسبة للزي value هو it's how much deviation from the standard deviation, how much the value is deviated from that. So
Yes.
how I understand it, that in order to have an accurate
Yes.
we don't have that, so we just refer to the Z value of like the American population when we use the American Association score. Is that
Yeah,
right?
unless we have one of you develop a Z value for the Saudi population, which I think probably different. This is why the Japanese, they have a totally different Z value, because their body habitus is smaller than the American. And the American is different than the European. So it's totally different. As I show you, when you take a tricuspid Z value in a small baby with a body surface area 0.2, which is usually in unit square meter, tricuspid Z value of -5 in Dobeny Z score data set is 9 millimeter. But again, this 9 millimeter, if you take it to ROLAT data set, is only Z value of -1.3. I will not hesitate to take a patient with a 9 millimeter tricuspid valve for biventricular repair. They are suitable for biventricular repair. But if you take a Z value only of Dobeny, it's -5, is scaring for you to take the patient for biventricular. So this is the different. You should know which Z value that you are using.
So does that mean that maybe we should focus more on the other measurements of the adequacy of the RV, like the RV size, the partitions?
I think it's a collective. Yeah.
RV volume.
Is collective. How many parts RV is there? RV dependent coronary circulation, or even not RV dependent coronary circulation. Those with a significant RV to coronary fistulas. They may have. I remember I did at the time I was working in BCC. I did a PT shunt for a baby. Whenever we extubate him, he stayed for 3 days and then suddenly developed acidosis, and we have to reventilate. And then after a period of 3 or 4 trials, we studied him thoroughly. We found he's having a RV to RCA fistula, that I have to take him to OR to close this fistula. So, and then after that, he get extubated and did well. But again, you should look for all the variability before deciding which pathway you should take. But we are lucky, because when I started the training, this patient goes for RV RVT patch, and usually they are very sick in the ICU, very sick, and mortality is not is not low at all. Around 15 to 20%. It's not something simple. But now we are lucky that cardiologists are taking all these patients.
Thank you, Dr. Abdularaoof, for this really comprehensive
حياكم الله. ايش السكند ليكشر يا شباب؟
lecture. And I
Right, okay. Okay, thank you very much. Bismillah ar-Rahman ar-Rahim. So the topic assigned to me is Epstein anomaly. And it's again one of the rare congenital heart disease, which is fascinating in the term that it has a wide spectrum from very sick neonates to almost asymptomatic when they present in some of the adult life. But the other issue is that they can present in all stages of life. Even if people have diagnosed them on the fetal echoes. And the time they present and the management also shifts in terms of the strategy of management surgically or medically. So I'll go through you with this. I have divided it into like the first part mainly how they present in the adults, and the second part how they present in the neonates and infants. And some of them there is some convergence, but I hope I will clarify the issue rather than make it more complicated for you. So this is the guy Epstein, who first actually described this lesion, and in almost all the details which we know now, and surprisingly, it was more than 150 years ago. So he described it in a 19-year-old laborer who died, and he was cyanosed. And Dr. Wilhelm Epstein, he described the malformation of the tricuspid valve and the right ventricular dilatation and myopathy, and correlated this anatomical findings to the symptoms of the patient almost 100% correct. As I said, it's not a very common disease, less than 1%. Prevalence is about 0.3 to 0.7% of all congenital heart disease. And again, on the red arrow, you can see that on the one side, you will get a critical neonate who is almost dying in your hands with cyanosis and low cardiac output. And then you see adults who just walk into the clinic and they say, oh, I'm a little bit dyspneic, or even mild cyanosis or palpitations. And echo shows, oh no, there's something grossly abnormal in their heart. So basically, there are three things which we need to consider. It is usually billed as a tricuspid valve abnormality, but it's more than that. Now, what is the abnormality in the tricuspid valve? The AV valves, they develop a process of delamination. Delamination, like one of the layer from the inner side that peels off from the other endocardium and myocardium. And this innermost layer, as it peels off, this eventually leads to formation of the valve leaflets. Now, this process is delamination. Like if you have laminated sometimes your documents or cards, they put a sheath of plastic on it. That is lamination. But if you peel that lamination, that will be delamination. So this process of peeling is deficient. It's not proper in these cases. So that the septal leaflet still continues to be attached more to the myocardium of the right ventricle. And so is next to it is the posterior leaflet. The most mobile leaflet is usually anterior leaflet of the tricuspid valve. As you know, tricuspid valve, we tend to describe it as having an anterior leaflet and a septal leaflet. and a relatively smaller posterior leaflet. Not only that, the leaflets are also dysplastic, and the anatomic where the valve closes, that displacement of the functional annulus is toward the apex of the heart. And I will show you some pictures and that will clarify a little bit more. In addition to that, a large part of the right ventricle, which is more toward the right atrium side, the part which is above the functional annulus, tends to become dilated and thin-walled, and also loses to a variable degree the number of myocytes in it. So the RV becomes atrialized, so it becomes thin-walled and just doesn't contract well. And the more the portion of the RV becomes atrialized, the worse the child or the person would be in terms of the symptoms and outcomes. Another important thing which we should, as a surgeon, should not underestimate is that they are prone to arrhythmias, and especially Wolff-Parkinson-White syndrome in about 15% of the cases. But they can also have other accessory pathways, and this can be troublesome. This can be the cause of symptoms before we intervene, or this can be actually a complication after you have done something and then you cannot stabilize the patient. So if you can see this one clearly, then look at the top one. If you open a normal tricuspid valve at the level of the crux of the heart, which is here, all the leaflets are attached on the same position. This is where we find the normal tricuspid valve annulus. All the attachments are there. Though anterior may be bigger than the posterior and the septal, but they are attached in the same way, in the same plane, sorry. In Epstein, the anterior remains attached pretty much in the normal position, but the attachment of the posterior and septal is displaced towards the apex of the heart. So and this amount of displacement, the more it is, the worse is the anatomical and clinical situation of the patient. Now they also talk about Epstein of the left side because, as you know, in corrected transposition, the RV may be on the left side, and they can also have Epsteinoid valve. Now there is a little bit of difference. All the left-sided Epsteinoid tricuspid valves, they are not associated with any atrialized portion of the RV. So yes, the tricuspid valve is displaced, the functional annulus is displaced toward the apex more, but there's no atrialized portion. But anyway, it comes in the descriptions. But basically this, in the one in the middle, Epstein on the right side, is the one which we usually encounter. So this is how it will be, that we have a huge dilated right atrium because of the regurgitant tricuspid valve, which can be dysplastic as well. And if you focus here, actually the right ventricle is just here. This cavity left is right ventricle. This ARV represents atrialized right ventricle. This all was the right ventricle, which has now become thin-walled and actually functioning like one cavity with this right atrium. Now, if you see that all this chamber, which has become one kind of a giant right atrium, may be actually bigger in the volume compared to volume of the other three chambers, which are the normal right ventricle, or whatever right ventricle is left, and the left ventricle and the left atrium. And this is also a basis of classification, which is followed mostly in the pediatric cardiology circles to predict the prognosis. And one system of classification is basically based on how much is the ratio of the volume of atrialized plus right atrium proper in compared to the other three chambers of the heart in diastole. And we will go there, inshallah. Now this is actually by chance last week they presented in our center here under the subdivision of the adult congenital people, that a 37-year-old lady who is primi gravida and she desperately wants a child has just presented with palpitation for the last 2 months, and she's only pregnant for the last 3 months or something. And her room air saturation is 95%. So if you focus on this X-ray, what do you see? Any volunteers?
Normal, except maybe absence of the thymus, but it's normal.
Yeah, normal, almost normal looking.
X-ray.
Normal, but
Yeah.
there is something. It's
Dilated RV.
Yeah, you could say dilated heart shadow.
And
There's a little bit narrow pedicle of the heart, and the lung is not that much plethoric as you would expect with a dilated right heart in an adult. So yes, you can pass it on sometimes as a normal X-ray with some dilated heart. But this was her echo. Actually, it's a little bit inverted image. So you can see that this is the right side, and the tricuspid valve is closing here, while the mitral is closing up here. And this distance is more than 2 centimeters. This is usually they tell you in adults this much centimeter, then 1.5 centimeter. But I'll give you another more accurate measurement, which you can apply in different sizes and of the hearts. So this all is the atrialized right atrium and the normal right atrium, which is dilated, and the apex of the heart here. So, and if you see it in with some color, you can see there's some regurgitation of that tricuspid valve, and there is some small chambers, which is actually the RV now. This is the functional RV or right ventricle now. We will go to the next one, and so we saw the apical displacement of the functional tricuspid annulus more than 8 millimeter per meter square. I would like you to remember this 8 millimeter per meter square rather than 1 centimeter, 1.5 centimeter, because this has more practical application. And that's how it is, that atrialized right ventricle, then this is anterior leaflet, and this is the portion of the ventricle which is left. Ventricular septum is here. The septal leaflet is also tethered, and some portion of the left ventricular outflow tract is shown in this picture. As a surgeon, when you look at it and you open the right atrium, you would just see this tricuspid valve, which is almost entirely the anterior leaflet. You will not be able to see on the first glance as you open the right atrium the other leaflets which are displaced towards the apex of the heart. And what you see here is atrialized portion of the right ventricle. It doesn't look like atrial wall, but it is thin walled, and it is just functionally contributing to a large right atrial size. Now what happens, the deformed tricuspid valve, not only because of the displacement, but also the leaflets may have fenestrations and some also dysplasia. There is regurgitation of the blood, and the regurgitant volume will all enter back. So this, like by back, I mean it will go toward the right atrium rather than going towards the right ventricle. So less amount of blood would be ejected to the lungs. And the atrialized portion of the RV would work as a pressure sink. It will put even the functioning contractile RV, whatever is left there, at a disadvantage. So when this little RV pumps, a lot of it goes back and very little will go forward. And then there is usually there's more than an enlarged PFO. It's actually, lots of the time it's like a ASD. And through this ASD, this blood will shunt from right to left. So more blue blood will go to the left side to be pumped up. And progressively, as the RV dilatation increases, the annulus of the tricuspid valve continues to stretch, and they progressively in their life, if they were not very cyanosed before, they continue to progressively become more and more cyanosed. Part of it is this dilatation and shunting right to left. If they are not treated, for example, then what do they suffer in their life from is cyanosis, almost universal, some degree, maybe mild in adults, but can be very severe cyanosis. Because right to left shunt at the atrial level, as I tried to explain to you. And worsening of the cyanosis in adult life can be due to the paroxysmal arrhythmias. But once the cyanosis appears, then it progressively worsens. The other issue is palpitation and SVT in as many as 1/3 of the patients, which, as I explained to you, they have more accessory pathways, including WPW syndromes. And some of them can actually die suddenly because of fatal ventricular arrhythmias. So electrophysiologist has to be part of our team managing these patients from the beginning. In the adults, the Carpentier, the famous French surgeon, he classified them into 4 types. Type A, where he thought volume of the right ventricle is adequate. Type B had a significant atrialized right ventricle, but with a mobile anterior tricuspid valve leaflet. Type C, he says, the tricuspid leaflet is severely restricted. And a restricted anterior tricuspid valve leaflet will cause RVOT obstruction. And RVOT obstruction, in addition to the other pathologies, adds to the misery in these patients. And they become more and more challenging and difficult to manage. Type D is near complete atrialization of the right ventricle with only infundibular part left, just like a big balloon, almost all of it on the right side, which is atrialized right ventricle and right atrium, and large right atrium. So I want you to think of Epstein anomaly not only as a valve abnormality, it's also an RV underlying myopathy. And the dilated functional ventricle is thinner and has fewer myocytes. And this has been proven quite effectively by the MRI studies as well. So RV myopathy is part of this pathology. But there is more to it, which is actually coming more and more clearer recently, that there's also abnormalities of the left ventricle morphology. And a series of 106 patients in Mayo Clinic, 38% had some form of the left ventricular dysfunction, morphological and functional, and surprisingly 18% had ventricular dysplasia resembling non-compacted left ventricle. So a dysplastic, displaced, malfunctioned tricuspid valve, almost impaired RV with a dilated right side, and abnormalities of the left ventricle and arrhythmia. You should think about all of these when a patient is presented to you. Associated lesions, obviously, most of them will have an ASD, almost up to 94%. But some of them will have other associations, and the worst one are which have an association a pulmonary atresia. So there's a small RV which was hardly pushing any blood to the lungs. Now you add pulmonary atresia or hypoplastic pulmonary arteries to that, and the situation gets from almost disastrous. So how do they present? They can present, as I said, in fetal life, and they have been diagnosed on fetal echo, incidentally, when they do it. Don't ask me how, but ask somebody who does fetal echoes. Neonates and infants can present right from the early stages in their life with cyanosis and or severe heart failure. If they survive with the medical management, they survive because they improve their pulmonary vascular resistance. Now, as you all know, as a neonate, their pulmonary vascular resistance is high. So this small, miserable looking RV is trying to push against a high pulmonary vascular resistance is more likely to fail. But if they survive with medical management and the pulmonary vascular resistance tends to fall in the coming days and weeks, they tend to improve. And adults can present all with the vague symptoms, or even sometimes I would say they would say no symptoms. I'm fine, but some fatigue, some palpitation, and then they can present with severe right-sided heart failures or arrhythmias. So now this is little bit, what is the medical management of these patients is antibiotic prophylaxis for infective endocarditis. And actually the recent guidelines for the American and the European guidelines for the antibiotic prophylaxis do not recommend in the untreated Epsteins, though they are blue. But this is not the practice. I actually asked one of my colleagues who is an adult congenital guy, and he said the practice mostly in Saudi Arabia is that we do prescribe them some antibiotics for infective endocarditis if they are going for any dental treatments or other invasive procedures. But obviously when they are treated and you have some patches or shunts or other materials, you have to treat them with infective endocarditis prophylaxis as you normally do. Then therapy for heart failure is basically diuretics and ACE inhibitors and sometimes digoxin. More important than that is arrhythmia treatment in them with antiarrhythmic drugs and radiofrequency ablations if it is required, then that should be done to improve them symptomatically as well as their long-term outcome. Right. So in adult patient, what are the indications for surgery is actually in the milder form when they present to them. The echo may look horrible, but the patient is very little cyanosed and though the valve looks very much displaced toward the apex and his functional capacity is good. I mean, he's not in an advanced New York Heart Association class, but still, if on the chest X-ray the cardiothoracic ratio is greater than 0.65, like 2/3 of the or bigger, then that's an indication for surgery. But obviously, if they are in heart failure or their exercise capacity is very limited, 3 to 4 New York Heart Association classes, then they are indicated to go for some surgical correction. Then history of paradoxical embolism or significant cyanosis, 80% on room air, polycythemia with a rise of hemoglobin above 16 grams, and arrhythmias refractory to medical and radiofrequency ablation is also considered an indication for surgery. We are talking about adult patients. Now, if you don't treat them, or even if you treat them suboptimally, then they can have all of these: congestive heart failure, sudden cardiac death, endocarditis, brain abscesses, strokes, and ischemia because they have shunts on the atrial level. Now let's shift gear a little bit and go to the other spectrum of the disease, how they present in early life and as neonates. You just seen an X-ray looking like this. My friend said that this is pulmonary atresia with stenoid valve. Actually, if you see an X-ray like this in a neonate, so-called wall-to-wall heart, then I don't think it's anything else but a severe Epstein. You are safe to say this is an Epstein. And look at the heart, almost occupying everything in the chest. And this with a blue baby, that almost pretty much clinches the diagnosis for you. So if you remember the very nice picture which I showed you in the second or third slide with the dilated right atrium and atrialized right ventricle, that is taken as a one chamber, and that was compared to in the diastole to other 3 chambers, and the ratio was compared. And this was done by this man, Sellermeyer, and I think it was done in Great Ormond Street, so that's what's called Great Ormond Street echo score. And if it is less than 0.5, like this combined chamber is half of the size of the other 3 chambers on echo, then they don't die. The risk of death is 0. But if it's equal to the other 3, then the risk of death increases to 10%. But if this combined chamber ratio to the other 3 chambers is more than 1, like it is 1.5 times bigger than that, then the death percentage tends to increase. And when it goes above 1.5%, the atrialized right ventricle and right atrium is 1.5 times or 2 times bigger than all other chambers combined, then almost 100% risk of death in these children. So when they are severely stenoid and they present as a neonate, they will present as blue, right heart failure, low cardiac output. So if you try, medical management is try to decrease their pulmonary risk resistance with pulmonary vasodilators and see if we get away with it for some time. But also at the same time assess the RV outflow tract carefully for anatomic pulmonary atresia or stenosis, which is a risk factor for both early and late mortality in these children. When we go to actually I'm very fond of this natural history. All of you should try to see that, and that there are almost textbooks available telling you about the natural and unnatural history of congenital heart disease. Like what would they do if you could not do anything, and how would they do when we do everything? And some of them is very sobering reading. So of all the neonates with diagnosis of Epstein, actually almost 20 to 40%, let's say 1/3 will not survive 1 month, and less than 50% will survive 5 years. And the same guy, the one who did Sellermeyer, who did this Great Ormond Street echo classification grading, he reviewed 220 cases and he followed them, and he says 1 year actuarial survival was 67% and 10 year 59%. And I think this is the one in which they had some management, medical intervention or surgical. But the predictors of death for severity of echocardiographic grade, which means how big was the right atrium and atrialized right atrium, and fetal diagnosis, obviously when they are anatomically worse substrate, they will present early, and right ventricular outflow tract obstruction, which adds another misery to this condition. So what is the indication for surgery in neonate? Now babies who are profoundly cyanotic and are in heart failure, despite our medical management, they need to go for surgery. Asymptomatic neonates with a score of 3 or 4 on Sellermeyer scale, which means a very large atrialized portion of the right atrium and right ventricle, they need to go for surgical palliation or correction, mostly palliation, I would say, in these children. And symptomatic neonates, even with mild cyanosis, who are actually good, but their hearts are very big and CT ratios are very high, or has severe tricuspid regurgitation, waiting on them or trying to optimize them is not going to get us anywhere, so you have to intervene. This is from the textbooks. You will see this algorithm. And if there's basically if there's a good antegrade pulmonary flow and good anterior leaflet, then they can go for biventricular repair. But in addition to all what they have with the tricuspid valve and the atrialization, if they have pulmonary atresia or hypoplastic PA, then you don't have a choice but to go for a single ventricle repair. There's something called a functional pulmonary atresia. If they are stable and they have good anterior leaflet, then they go for biventricular repair. But if they're unstable and they have poor anterior leaflet, then they go for single ventricle. And if the LV is also poor, now RV is already almost giving up, and add to that an LV poor, then unless you have the luxury of a heart transplant, you can't help these babies. What was the single ventricle repair? In the previous talk, I think Abdularaoof mentioned Stan's procedure, which is actually converting them to a single ventricle. They have a small RV, they have a dysfunctional and dilated dysfunctional tricuspid valve with a dilated annulus and all these issues. So actually you exclude the RV. Put a patch on the tricuspid valve. This is a patch on the tricuspid valve, closed shut. So you have excluded the right ventricle side. Leave a small fenestration of 4 millimeter in there, which will make it the Thebesian flow which goes to the right ventricle. It will be an egress for that. Otherwise, the right ventricle has to have some blood inside, some venous return. Where will it go? Enlarge the ASD. So the ASD which is present there, or foramen ovale, you have to make it bigger, and do a systemic to pulmonary artery shunt. So now you essentially you have done something, made him a univentricular heart in all respects. Whatever the vena cava blood is returning should go to the left side through the ASD which you have created. There's no functional RV, nothing will go forward in whatever pulmonary artery is there, and you do a systemic to patient. To be honest with you, in my career, I've seen only one, and that was severely what I say, he gave us a very hard time in the ICU, but he did recover eventually, and he was a neonate, and the heart was, as I showed you before, wall-to-wall heart and a blue baby. But for the first couple of nights, actually you have to pull your chair and sit next to him, giving him a boluses of this or that, and trying to manage him that way. So this is the stance procedure. It's rarely done, but this is the one you can do for a single ventricle in these kids. Now for two ventricle repair, you want to use whatever right ventricle is available to you to supply the pulmonary blood flow, more or less. So you have to repair the tricuspid valve, and one of that is that you convert it into a monocusp valve. As the anterior leaflet is mobile and usually large, you use that, narrow it down a little bit, you mobilize it, reattach it to the more toward the anatomically correct position, plicate the atrialized portion of the right ventricle, narrow the annulus, and leave a small ASD. This was not Craig repair, which is done in the neonates and or smaller children, and it does work. And if they have a reasonable portion of the RV, they survive. Though with the ASD, they may still not be. You may not be getting saturation in 90s, but you will be having a surviving child with saturation in 80s, and he will improve. So the plication of the atrialized portion is done in a way that you have to take care. What is on the outside of the RV?
Coronary.
Yes, right coronary. Yeah. So the right coronary is one thing you need to worry about, and the other thing is, if you are plicating and all of it looks like a right atrium to you, then there's a coronary sinus and the conduction tissue around it. So be careful with that as well. And then you plicate it. By plicate, we mean, as you can see it in this diagram, that put some plagiated sutures and pull it together and make it narrower. So if you plicate it vertically, the ventricle will stay longitudinal. But if you plicate it horizontally, the ventricle may appear even smaller than what you like to see it. Now, this is a slide I borrowed from Abdularaoof. It shows very nicely what is the current, or well, not very current, but up to 2011 was the situation. And you can see that the in-hospital mortality by management strategy overall was 24%. Obviously the one who are medically managed, they are the good ones. Even them had a mortality of 22%. The one who just needs some interventional cath, I think they are a good substrate anyway. So their mortality, in-hospital mortality was 7%. But the one who needed cath and surgery, you can see that 64%. And anyway, systemic to PA shunt, 27%. Tricuspid valve repair, which obviously an attempt at biventricular repair, is 31%. Single ventricle palliation stance procedure is 36%. Now, if you, and transplantation, they reported 3 cases with no loss. But if you look at that, this is, as somebody said, worse than the first stage no root palliation, which is true. It's very high mortalities, despite what we know at the moment and the best efforts. Right. So let's go to how we repair the Epstein in adults. We talked a little bit about pediatrics, that we can go single ventricle, or we can try to repair the tricuspid valve and leave some right to left shunt and palliate with in that way and follow them closely. But when they come to you in adult life, then there is certain basics. Again, there are lots of options available, and you have to tailor what is best for that particular patient. If you can repair the tricuspid valve, that is the best option. But if you cannot repair the tricuspid valve, then you have to replace it. And the general teaching is that bioprosthetic valves are preferred in the tricuspid position. You may plicate or resect the thin-walled right ventricle, depending on what you find and how much you find there. And associated septal defect you may close, or sometimes you leave a PFO or some right left shunt. Certain names you have to remember. If I don't think in an exam they should ask you about the details, but if somebody asks you, any operation about Epstein, you can say at least a couple of names in adults, so that they know you probably know about it. But I don't think it would be fair to ask you how exactly this operation is done. So the one who popularized one Danielson technique, Craig Danielson, he said he used to plicate it horizontally, narrow the tricuspid valve annulus, create a monoleaflet valve, the same as we discussed in the children. But this Danielson, I think he's still working in Mayo Clinic, and he continues to modify his technique, and he continues to update people about what are the modifications. And this is one thing I think we should do. If something is rare or whatever, then one person should take it as his subspecialty in the subspecialty and continue to do it and improve. And that's how we will get improved result in rare situations or very difficult situations. So this is Mr. Danielson, as you can see him. And basically he does this, that he narrows the annulus, brings he detaches and anterior leaflet to a little bit, so that he delaminates it from the other portion and brings it, resutures it to the more anatomical position. It's already half of it is in the anatomical position at least, and plicates that atrialized right ventricle, and does a posterior reduction annuloplasty. But recently he has added annuloplasty rings to that, and the current modification, which is called Mayo Clinic modification, there is something called Sebening stitch, which is to bring the anterior papillary muscle toward the ventricular septum by taking a pledgeted suture, and that's how the tendini and the papillary muscles become more aligned to the narrowed, smaller orifice valve with the monocusp situation, and it seems to have improved their results further. And this was more relatively recent publication from the same group. Carpentier actually has something similar. He detaches anterior and posterior leaflets. He again narrows the tricuspid annulus to more or less like a normal size, but he adds longitudinal plication. So the difference between Carpentier and Danielson in terms of technique is a few points, including the longitudinal or vertical plication of the right ventricle. Because Carpentier thinks that longitudinal plication leaves the ventricular shape, the residual right ventricular shape, more like a bullet shape or longitudinal shape. This is the latest one to this surgical techniques which are available to us, which is called cone repair. It was by De Silva, and initially people had a lot of skepticism about it, but it has produced reliable and reproducible results in different parts of the world, including in Saudi Arabia. And it can be done. Though when you look at this in an adult and with severe abstenoid heart, and you open it, for a few minutes you will think, oh, it cannot be done. But if you follow the steps as De Silva described, eventually you get it and you are amazed by the result. The tricuspid valve becomes functional. Now, why it's called cone? If you look at this cartoon, this is before repair. The tricuspid valve only anterior leaflet is attached more towards the normal side, normal annulus. The other leaflets are dysplastic and small, and they are displaced toward the apex of the heart. This is the atrialized, in a cartoon, atrialized right ventricle. And what he does he detaches it and reattaches, makes it smaller, plicates this portion. You will see a nice video about it. And all of this appears like a cone, like your ice cream cone, it makes it a cone. This open sail-like thing becomes a cone. So that's why it's called a cone operation. And this operation has actually, I would say, that kind of revolutionized, and more people are adopting it. So in pictures, it appears like that. That if you see this first one, you see the big anterior leaflet and atrialized portion of the right ventricle. Then you mobilize the leaflets. Actually, there's a very nice video. You will see how much you have to mobilize right down to the attachment of the chordae and towards the apex of the heart. Sometimes up to 3 to 4. It appears like about 3 centimeters. You have to keep cutting, and then reattach this detached leaflet posterior and septal back to the anterior leaflet, like he's doing it here in the picture C. And then you add an annuloplasty ring, and you have plicated the atrialized portion of the right ventricle behind it, so you narrow down the annulus. The annulus was initially like this big. Now you try to narrow it down to more of a normal size. I just put it. Sorry. Yeah.
I'm not sure, but I think there is no annuloplasty ring in this technique.
People have added it. People have added it from time to time, and even in some of them, when they don't work well, then even a Glen can be added to bail yourself out.
Okay.
Yeah. So cone repair, I just added this slide because actually this is a description. I find it nicely. I just added it for you. You keep it I keep it in my record, and if I get an Epstein to repair, I go over and read it again to where to start delamination at the 12 o'clock position when you're looking from the surgical view. Continue clockwise, like a clock goes 1, 2, 3, keep going till you are back to the anterior leaflet. You have mobilized all the inferior and septal leaflets, and then reattach the cut ends to the anterior leaflet, and that's how you make the cone on the top, which is attached on the other end with its chordae and to the capillary muscles. And take care of when you are plicating the right ventricle of the right coronary artery and the conduction tissue. This is like a very nice operative video. Initial part of this video doesn't have a good sound, but the later part has it. I want you people to watch it. It's pretty much self-explanatory, so I leave you with this. So this is basically all anterior leaflet, which you see there. This is very rudimentary septal leaflet, and the area which he was pointing to is the atrialized portion of the right ventricle. So that's how the cone repair is done. Uh, somebody asked the question that don't add. Yeah, initially they don't add, but there are instances when they have added this annuloplasty rings.
So they didn't. Sorry. So they didn't applicate them.
He did not show it in. He did not show it in this video. He just showed you the details of delamination and how to bring it up with a normal anatomic position.
Usually we are plicating before attaching the leaflet, right?
Before.
Oh, okay.
Yeah. But there are some contraindications which are, I think, like we cannot do them in neonates. We have a smaller valve, and we cannot just produce a restricted valve which doesn't grow with the child. Or age greater than 50 years. I don't know why, but this is, they mentioned, actually this is from Da Silva himself. Now, severe LV dysfunction, yes, this is a contraindication. If you don't have any septal or inferior leaflet tissue at all, then you will not be able to create a cone. You cannot just rotate the whole anterior leaflet to a 360-degree attachment. Or will they say very severe dilatation of the true tricuspid valve annulus, which will be in extreme cases or neglected ones. So choose your patient properly, and then you can you have a good result, a reproducible result, I must say. But keep other options open as well. Like one of them is to, if you're coming off bypass, you cannot come off bypass. His RV is not maintaining a good cardiac output. Goes back, you have to go back and back again. Then add a glen that might take some load off the ventricle, and you may be able to come off to bail yourself out. Now, when we go to tricuspid valve replacement, now replacement actually the only thing you need to take care of. Well, unfortunately, this is showing a mechanical valve, but initially I said you have to do preferred tissue valves, but people have put mechanical valves. But any valve you put, you make sure that your suture does not interfere with the conduction area. And one of the methods of doing that is to go very posterior to the AV node and coronary sinus. So you close it toward the RV side. You go behind it while you're taking your sutures. If you are careful in an adult patient, I don't think you will need it very often. If you see here in this part of the diagram, here it is, he's on the true tricuspid annulus, but here he has gone deeper into the atrialized portion of the right ventricle and used that to bring the needle out, plicating as well as supporting the valve, plicating the RV and supporting the valve. So one of the recent papers which I came across, because is a series of 4 or 5 patients reported from Iran, and they got away with this homemade technique of putting a valve inside a pericardium, so making a skirted valve with a skirt, and not bothering too much about doing too much to the annulus or whatever, and just stitching this big skirt to the margin of the whatever hole you look at, the dilated tricuspid valve annulus, and get away with it. We don't have any long-term results on that, but they claimed that the medium-term and short-term result was good. Now, one note of caution for all of you. As a surgeon, we tend to sometimes underestimate certain things. Do not please underestimate arrhythmias and reentrant tachycardias and aberrant pathways in these patients. Go looking for it and get help. WPW syndrome, they say, is 14% of the patient, which is not a small percentage. And more than that, will have some form of atrial arrhythmias due to reentrant pathways or accessory pathways. And you may need to do in radiofrequency ablation before you take them for any surgical intervention. So to conclude, is a rare anomaly, less than 1% of all congenital heart disease, wide anatomic spectrum, severe cases have almost totally atrialized RV. And surgery is also, like the spectrum of the disease is wide, the surgery is also goes from 2 ventricle to single ventricle to heart transplant. And despite our advancement in management, both surgically and in the medically and in the intensive care, neonates can have very high morbidity and mortality, which is, I think sometimes prohibitively high mortalities. Thank you very much. So any questions?
Thank you, Dr. Atizaz. Do we have any long-term follow-up for these procedures?
Actually, De Silva, he for the cone repair, I found one for up to 15 years, and it seems to be doing well. But you know, when we talk about long term, unfortunately, as a surgeon, we talk about 30 to 40 years. Unlike cardiologists who are talking about 30 to 40 minutes or 30 to 40 days. Our long term is really long term. We think we'll operate on a patient, he'll go home, we'll never see him. But cone repair is going to has, in my to my understanding, has a better option. But again, you'll have to fit your procedure to the patient and find the suitable substrate and get a good result.
Thank you very much.
Yeah.
Thank you, Dr. Atizaz.
No problem.
Any other question from other resident? Okay, I think also Dr. Hani Mufti, he's with us. He will present the next lecture, but